name is Renata CIFKOVA and I'm from Prague, Czech Republic. My topic today is hypertension in women, with a specific question whether women should be treated in the same way as men, or whether we should use some different approaches for them. I will divide my talk into two parts. The first one will deal with hypertension outside pregnancy, and the second one will be specifically devoted to hypertension in pregnancy. So for the first part, we have to acknowledge that there are some differences in the pathophysiology of hypertension between men and women. However, so far, these didn't have any consequences for treatment. So in other words, basically the blood pressure response to antihypertensive drugs is about the same in both genders. For sure, there are some rules like that AC inhibitors, ARBs and direct renin inhibitors should not be used in women of childbearing potential. And this has again something to do with pregnancy, because these three classes of drugs are strictly contraindicated in pregnancy, because angiotensin II is needed for the healthy development of the uropoietic system of the fetus. So that's why we can't use these drugs. The critical period is the second trimester, however, we can't suggest them at all. For pregnancy, the gold standard drug seems to be methyldopa, which is otherwise an old-fashioned drug. We don't use it anymore outside of pregnancy, or very rarely. But in pregnancy it has a specific position because it's a drug which has the best safety profile and is considered to be effective. And it's the only drug where we have some longitudinal data regarding the babies, regarding the children which were followed being born to mothers who were treated with methyldopa in pregnancy. So if I have to summarize what's new for hypertension in pregnancy and regarding treatment, unfortunately we do not have any new data, any new trials, so we still recommend methyldopa. If methyldopa is not available, then calcium channel blockers, particularly nifedipine. Then we can go also for calcium channel blockers and less frequently for beta blockers. Hydralazine intravenously is not suggested anymore to be used because it has been associated with a number of side effects.